Good afternoon, everybody. It feels so good to here among young people. Uh, when it comes to capacity building, we were just discussing alongside here that uh, in the past 4 5 years, when we are running the Ayushman Bharat Digital Mission, uh, in this I'm talking about the digital health mission which we are implementing. But in my experience in government, I think this is in general that we take capacity building for granted. We think that trainings have to be done. It would be done. Uh, However, in the past 4 5 years, we have realized that capacity building in one aspect where, among many other aspects, where particularly in the digital health mission, we should have done more um, than what we had done. And this was primarily because it was one of the many things that we were doing, and we were doing it in an organic mode. We were doing it automatically. There is capacity building team in our organization, and um, as and when trainings we organized, we did that master training and and other and other related aspects. But to be very honest, we did not give it the focus that it requires. And particularly when it comes to ABDM 2.0, we are mindful of that. I also want to say that uh, the effort that has been put up in Uttar Pradesh, given the scale of Uttar Pradesh, if it has been done in Uttar Pradesh, it can be done in any part of the world. So kudos to all of you who have brought it forward and who have taken it to its conclusion. Um, in the coming phase, when we think about capacity building for the next 5 years, while we are thinking about the strategy for ABDA 2.0 next 5 years, what uh, what I would admit also is that we still do not know how it is to be done. We still uh, think that there are a lot of things that need to be learned. It is capacity more than a science. We were just having a conversation wherein, like for the scan and share, so suppose a citizen has to be taught or to be trained as to how to generate a token. The current thing that we have put in public facilities is a standee, and we have shown this is step one, this is step two, step three, step four, all very prominently, all the screenshots, everything given uh, properly over. We think that this should work, but what we actually find is that people have a look at that, but they still look for somebody in the crowd who can come and help me. भैया please कैसे करना है बता दो. So is there a way in which we can make a video, make a QR code which takes the user to a video, or we do it in a more interactive manner? So things like that we have to really really think about, and that is why I strongly feel that capacity building is more of an art than a science. And yeah, these are some of my statements. Thank you.
Thank you, sir. I would now want to request Anaita to maybe start with her opening remarks.
Thank you. Feels like a full circle in many ways. I was not with the Gates Foundation when I worked on this. I was working as a consultant with the UPTSU, and 50% of my time was with the Gates Foundation and writing this proposal, and then COVID hit. And here we are today. So it feels like a long yet journey we are still on, which is commendable. So thank you for everybody for putting this together. I think I'll just take a step back as we're trying to in my earlier capacity, pitch this idea and also negotiate on what this idea really looks like. Every time we went on the field, I remember this one time I was talking to an ANM and she was like, she was really upset and like flustered. And I was like, क्या हो गया बताओ तो सही कुछ as usual हम तो वहाँ जाके डिमांड कर रहे हैं ये ऐप ठीक बनी है इसमें प्रॉब्लम्स क्या हैं बताओ इसको ठीक कैसे कर सकते हैं आप इतने डिजिटल रजिस्टर्स का प्रयोग कर रहे हो 40% टाइम आपका लग जाता है सारे यूजुअल क्वेश्चंस राइट मेरी ऐप डिलीट हो गई थी मेरा डेटा उड़ गया मैं बहुत टेंशन में हूँ मैंने रजिस्टर में नहीं भरा था पहली बारी. So it's like, great, okay, step back, right? We have here tried to work across ensuring these 42 plus applications which were there at the national level, 80 plus applications as per our research in 2018-19 in UP that are just for digital health. Try to come together, streamline effectively. And then one of the principles we all learned, design principles, was offline functionality in applications. But did any of us go on the field and actually explain what that really means? Because here we were in our heads enabling them with the functionality that didn't exist. But did that conversation really happen with them? And I think many such examples before this, we were all discussing that we're talking about a diverse population, right? In terms of not just the cadres, but also within the cadres, age groups, educational levels, so on and so forth. So a lot of time, the Ashas and the AMs who are amazing in what they do, maybe a little elderly and maybe, using phones probably even for the first time fully owned by them. And we've not taught them how to increase the font size, right? Nobody had that conversation with them. Switch on, switch off, electricity, kahan charge karna hai, nothing, right? So I think that was one of our inspirations. But when we were trying to make a case for some of this, it was also like, we talk about health system strengthening, we talk about the 6 building blocks, WHO talk partners, they talk about now public infrastructure and human capacity being like the twin pillars of resilience for the health systems. Are we really talking to the user? Are we really understanding how all of these things actually truly enable them to deliver the services that they are ought to? Because we're all talking about this in a little bit of echo chambers, if I may. And that was the start to start thinking about what does that really translate to? ABDM was just coming up in its full entirety. The blueprint was already out. And one of the big things that the UP government had for the first time done through COVID was look at end-to-end case management. And that had never been done before at a unitized level. Like if you are giving phones to the ashas for the first time, you're doing all of this with a digital divide of about 37%, which gets even worse in the urban rural, which gets even worse for women. How do you truly make this useful? And with that, I think the idea came to want to embed some of this in the construct of what does across levels, whether it is a frontline worker, a CHO, or MO, a facility manager, a pharmacist, a lab technician, district officer, what does their journey of leveraging digital truly entail? And what are the skill sets we need to bring them on to be able to perform that journey? And I think around the same time, Mission Karmyogi also came in. And the IGOT fracking framework became one of those cornerstones, which could then be layered to make this a lot more. You can build frameworks in silos and then be like, this is a state-led framework, but to actually standardize something like this and make it applicable across the entire country, and now it's being shared by WHO even beyond, I think those were like stepping stones to be able to get here. And I just wanted to go back to what Anand was saying, that this is just started. We've found some success in UP, but one little good thing that happened very recently was the Meghalaya government team, health team, recently visited visited UP, and we have the privilege to also support them. And this was some of the work we had shared with them. And they saw this, and the first thing they said was, let's start with this. So I feel like if we were talking about this earlier as well, if the space is not created to build capacity will never get built, because always there is something important to do. And I think that ownership and recognition coming in, especially in the stage and phase of AI, becomes really important, because before we start to dump a lot of more tools and fancy stuff onto everybody, we really need to ensure that we're on the same page of what their needs are versus our assumptions of what their needs are. I can pause here.
Yeah. Thank you so much, Anaita. Anand, maybe you want to give your opening remarks?
I'm going to take a more different track rather than repeat what they already said. All of us are savvy digital savvy people. Yet, I'm sure when you pass through an airport, you see people like you and me struggle in front of the Digi. It's a simple device. All you have to do is stand in front of the camera. But just to mess with your mind, they change the location of the camera. They have this huge little device, screen. There's this woman. You think you're supposed to look at her face so that you get identified. But they tell you that you actually got to look at this little circle on the side. And that's so unintuitive, right? We've all seen people struggle with that. And when it doesn't work, you see perfectly people like you and me suddenly get flustered and say, what do I do? What do I? And we've all seen people like that. And imagine that problem being compounded 1,000-fold. You have somebody, as Anaita pointed out, who's using a smartphone for the first time. Now she feels that icon has changed. The icon has moved from one screen to another, or the icon color has changed, or the layout suddenly gets changed because some UI specialist thought this is going to be more intuitive to people. But in my state, 160,000 frontline workers, ASHAs, are there, and they suddenly are thrown off their game because some helpful soul thought the color should be different or that the layout should be somewhat different. It is really complex. The scale is large in healthcare across India. It's not just UP. The scale is large. The number of people out there who are all participating together is very large. The second aspect is that the people working are changing. We are losing nurses constantly from the public health ecosystem to the private health ecosystem. Somebody new comes in and they are only playing, forgive me for using that phrase, the Chinese don't like it, but the Chinese whisper game, right? So they learn from the person who's left, and they may spend maybe 15 minutes telling them this is what they are supposed to do. But that information which is transferred to them is perhaps good for when everything goes precisely right. If a small variation happens or somebody says, sorry, I've forgotten my Aadhaar number, I don't know what number I used when I registered for the Aadhaar, you're stuck. That person doesn't know how to take care of this. What are they going to do? The most natural human reaction is to say, this system doesn't work. And there are people all across the ecosystem who are saying these digital systems don't work because they run into these exception scenarios nobody's really prepared them for. I would like to think that those applications were designed to handle those scenarios. I'm willing to give those designers that, but that information has not been communicated to these people. And that is a big miss. That means they are not ready to handle the curveballs which normal life throws at them. That is the second problem, that these people change. So the person who comes in doesn't know enough. And the third is, of course, the domain itself is growing. I think in the last 5 years, thanks to the success of an intervention, you keep loading more and more stuff upon that intervention. I've heard very senior people say that the amount of work being given to the ASHA is very large. But the next time a new project comes in, a new intervention is pushed down the organization, finally it turns out to be one more menu, one more application, one more module on that poor soul's smartphone. The smartphone is not, may have the capacity. The human operating it doesn't have the capacity. So that's the environment we are working in. We may think that everybody, the doctors should be digital savvy, maybe. You think the younger doctors should be digital savvy, but actually not. They have other reasons for not wanting to adopt the system. They may not have understood the concept fully. So education capacity building is needed at all levels. It's not just the ASHA workers. I don't want to give the impression that only the ASHA worker who's perhaps not so computer digital savvy needs education. It's even at the very top end. We were speaking as a use case. We expect MOICs, CMOs to have analytical capabilities, but they may not. They're good leaders, perhaps. They're good managers, but they may not have analytical capabilities. So capacity building in general is needed at all levels. People want to see their capacity grow over a period of time, right? Nobody says they want more money. They always say they want growth. But so people want that. People want to see themselves grow. So that's the other reason we have capacity building, and of course, digital capacity building is the key to what's happening now and in the past. Very quickly changing. Thank you.
Yeah. So, Anantharaman, now I have the first question for you. You briefly mentioned during COVID how we saw the gaps with maybe ANMs and losing the data. I wanted to ask you the emphasis or the focus on this project even before the launch of ATM. What prompted the team to maybe think about capacity building, and more importantly, from 2020 to 2025, how those insights have evolved in from where you are seeing today? Something that we want to.
Thanks. I think Vikram sir mentioned this. Vikram sir mentioned this around our how nuanced understanding of digital is, and how when you assume that is a given, because if there is people are being able to use digital better, there is internet connectivity, etc. How that can transcend into a lot of problems for you, right? So when we were thinking about our digital strategy here at the Gates Foundation, and more broadly, even with TSU defining with the government of UP on what the digital health roadmap for the state looks like, there were a lot. It was a beautiful 10-year roadmap that was developed for the UP government, but there was absolutely zero evidence to prove this can be happening if there was a human involved, because everything was supposed to be led by that. So there was an assumption that the phones will be given. There was an assumption that they will know how to use at every cadre level. There was an assumption that they will move from paper to digital in no time. There was an assumption that they will be procured and they will actually not required to be maintained over time. So like small things were just assumed because we had such a beautiful vision, which we are still trying to bring alive. And cut to, there was supposed to be 160,000 phones to be procured for the first time in the entire country for a full Asha cadre by the UP government. The plan for training was training of trainers. I think we are all, I'm sure, familiar with TOT, where there is one, and Zoom was so COVID had come in, so somebody is doing that, and then there is we start with one module, then we go to the next module, then we will take some feedback, etc. And we've done this. All of us have done this in some format, either for a verticalized program application, or we've done it for some horizontal application, or we have to report into a particular portal. So how does that portal work, and what is the data flow supposed to be, etc., etc. And we were party to this, right? We were also supporting the development of such digital solutions, or we were working with the government to actually do that in different formats. And we realized we can keep doing this. It's fine. We can keep introducing these beautiful systems. I used to work at this organization called the Magi at one point. Sitting under the mango tree is a construct, right? Like I will go there, spend time in the village, shadow the worker, understand what their needs are, draw it out on a paper. I can do all of that. But I have still not met them where I need to meet them. What is the value that is going to come to them? Right? That nobody is talking about. It's when we did this analysis for UP government, we realized of that 80 plus applications I was mentioning, about 70% of those 80 plus applications were useful for administrative purposes. As doesn't come as a surprise, but when you get a number, it just makes it a lot more easy to make a case for something like this. So that's why we took a step back and we were like, if we are putting some bets on digital, we eventually want this to also cater to citizens. And, if you're looking at electronic health records and ABDM coming in, how will you even explain what is the benefit of ABHA for anybody, right? So where do we start? And where does that conversation start to truly make it useful, not just for the administrators, but also for the users at the different levels in the care continuum? And that's how we started thinking about it. But we were very confused because it's not like capacity building is new. Capacity building training has been happening for a really long time. So, how do you think about it systematically in the advent of digital, leveraging digital, but not over indexing on digital? What's that hybrid mode supposed to look like? Do you need a separate center of excellence? Do you do this with an SHSRC kind of an equivalent which is where all the trainings happen? It was all blank, right? And there are already existing trainings happen, which are led, there's NH2 budget. How do you embed this? And all of this to say, if you take even a step back, medical students don't get exposed to digital solutions. They don't get exposed to being able to leverage EMR. And that's a very big opportunity, if I may, which we can leverage. So keeping all of this in mind, we're like, let's just start small, which is where the frontline workers came in. And, the idea was not just to focus on frontline workers. The idea was to create activity competency-based framework to A, help them grow, like Anand was saying, in their job, but B, also do that across the different levels. It is assumed that a data entry officer or a data analyst sitting at the district level or they will understand how to analyze data. It's very tough to do that. And they get into this loop of every time हमें Excel बनानी है, फिर PPT में paste करना है, फिर ये district review officer के पास लेके जाना है. But what if you meet them where their problem is? They have to do this mundane thing every month. How do you equip them to, build these sets, build this, automate some of it? And that's how some of this started. And I feel like even when one of the frontline worker applications was introduced in scale, it wasn't very intuitive. I remember 1 year into rolling out one of the frontline worker applications by the government, it was still a fight because when we used to go and talk to the ASHA and the ANM that अच्छी एप्लीकेशन हाँ बहुत अच्छी है ड्यू लिस्ट दिख रही है मैं आगे पीछे सब ट्रैक कर सकती हूँ वेरी गुड दीदी मुझे डैशबोर्ड तो ले आओ मुझे अपना काम का समरी नहीं दिख रहा है. So, and that took a while before that actually got introduced. So I think as we build their capacity, they'll be able to, and they try to already, need to listen in and lean in more, but we were able to better help them also articulate their needs so that they find the value. A lot of times we say, I was talking to somebody, one of our partners yesterday, and they were like, tribal populations may have told, digital use. Meet them where they are at. वो reels बना रहे हैं. So if you are able to actually meet them at what is the kind of mechanism through which and the pathway through it, maybe it's not a digital application, maybe there's another mechanism. So meet them where they're at and how do you start thinking about the value proposition when it comes to making it useful for them? Because ultimately you start tying incentives. You start making you make it punitive before you actually make it useful for them. And I think that was the gap we felt that if we want to support a digital strategy, we need to take responsibility for, and we found partners in the government and with UPTS.
Anand, you are not new to health tech. You have experience of looking at from global stage and also from maybe IT domain sector. But from last 3 years, how are you seeing that the digital transition happening in Uttar Pradesh, and especially how the health professionals are responding to it? Maybe some of the barriers that you have seen that it is them difficult to use this tool in their work.
So of course, it's a given that the pace is accelerating. 3 years ago is the way you stated the question. 3 years just after or towards the end of COVID, I think the verdict was in. Everybody in the health system recognized that digital systems can be a great aid in managing at least the national level, global pandemic. Therefore, acceptance of digital systems was somewhat facilitated by that entire experience. Add to that the fact that I think the UP government and the health department had already put into place a few things which were validated by the ABDM framework. For example, the UP government had put in place a HR system to make sure that all the health workers would be on a system. Similarly, they had already begun the process for maintaining a statewide public health facility registry. These might seem like the most mundane things, but they aren't, and at the national level, they mirrored the fact that these fundamental blocks were not clear across our large nation. And the fact that the same infrastructure was being now fed through the ABDM program made something more acceptable within UP based on we have since over the last 3 years done some very remarkable things. A lot of the people in here know UP historically has not been a champion for change. It was considered one of the backward states. In at almost every large metric you think about, UP was one of the backward states. And in the last 3 years, we have moved remarkably. Today, we are number one on almost every metric on the IBM dashboard, whether it is the number of HPRs, professional registered, number of health facilities registered, number of ABHAs created, number of EHRs. It would be easy to write this off as saying the state is big, naturally the numbers will be big. But that's not the complete story. It's also a good story from the percentage point basis, and therefore that is good. So there is overall greater acceptance. The systems, the roadmap, which Anaita referred to, that roadmap has seen significant traction within the state. Those systems have been built, scaled out, and today the state is actually at a stage where they are able to pick data from all these systems. Across systems, see them in a single platform called UP Swasth Kendra, which all the administrators are increasingly beginning to use, which lets them see by facility what is the human resources available there, what are the drugs available there, is there critical equipment functioning or not functioning, how are they doing in terms of budget, things like that. So it's important, and these systems have made it possible for them to take certain decisions faster, better, in more real time. I'm very proud of the fact that today in UP, if a lab test is done for a set of about 28 odd diseases, the administration, the state surveillance team sitting in Lucknow gets to know in about 24 hours. I would like to say it's instantaneous, but it's not. But that's where the digital literacy comes in. Those people do the work on paper and then do the data entry at the end of the day. But 24 hours is dramatic improvement over where the state used to be 3 years ago, where they would not know that in a village, there are suddenly overnight in the last 24 hours, 6 cases of dengue have suddenly cropped up, which therefore means you must rush in people to tell what could potentially be a somewhat wider spread, localized epidemic or an outbreak of that particular. So things are changing. That perspective, I think we are blessed to be in a time where UP is making progress. There is, of course, a spotlight on UP too. There's political will. I think the stars are in line. There's no way to go but forward. So that's where we are.
Yeah, largely barriers.
So the barriers to this, I would like to come back to the capacity. So systems have been built, but the roadmap is not internalized by everybody across the country. That there is a grand plan, that there is a vision, that each person's job has a specific function within this large spider web is important to understand. We recently executed one of the largest microsite projects in the country under the ABDM plan. We did 38 districts, which is 50% of the districts in UP. And as part of that exercise, one of the things we learned was doctors and healthcare professionals, nurses, are not yet aware of the value of a digital health record, or they don't see it quite the same way. They are like the 7 blind men touching different parts of the elephant. Somebody just only sees this, somebody only sees this, but they don't see the elephant as a whole and the value the ABDM construct brings to everybody in that entire chain. not just somebody sitting in the NXE in Lucknow or in New Delhi. The citizens don't see it yet. Sir spoke about the stand there. Those patients don't get it. They don't understand why this is so important. I'm telling the doctor what's my problem and why does he need to see my health record for the last 6 months or the last 3 years. They don't get it. They don't understand the Aadhaar ID yet. If there was some goodie associated with the Aadhaar, it would become at least sensible. But it's tricky that way. The directive is you cannot refuse services to somebody just because they do not have an Aadhaar ID. So the health delivery system does not kind of twist your arm to create an Aadhaar to get your healthcare record bill. So it doesn't do that. So there are quite a few challenges. I think the challenges are more in terms of understanding of why we are doing all of this. What does it mean to each person who's participating in this ecosystem and the citizens?
I can completely agree. We have seen that the whole information about awareness about ABDM as a mission in public and also in the healthcare professionals is something that I have seen in UP. Sir, I want to come to you with the question. You briefly mentioned about ABDM 2.0. With whatever we have seen in last 5 years with ABDM, we wanted to understand what does this next phase look like, and especially beyond maybe the digital infrastructure. What does 2.0 look like to build capacity of our health professionals?
So ABDM 2.0 means ABDM planning expenditure from April 2026 onwards for the next 5 years. So ABDM 1.0 was 31st March. In the past 5 years, what we have done is we have largely made the roads, we have largely built the technology. What we have realized is that adoption of those roads, adoption of ABDM, adoption of digital health has been a challenge. So the next phase of ABDM 2.0 is more about um, getting better at adoption, getting more use cases, doing more IC, doing more capacity building, um, and actually realizing the value proposition of digital health. Um, we were discussing a while ago that we go to a doctor and tell that you can create a digital records and you can also see digital records. Presently, the doctors ask that how is it valuable to me? I am patient is come seeing me getting a prescription in 30 seconds to or her, and I have so many patients. This is all done in such a small time. I mean, the entire um, paraphernalia of having a computer, writing the diagnosis, the symptoms, the medicines, the next follow-up is doesn't sense to the doctor presently. Even in the big hospitals where we have um, where we approached both in the government and in the private sector, we are seeing similar challenges. Some of them asks for incentives, say that the government hospitals, they say that it is the workload, the exact value. What we have done presently is that we have created something which is called as model facilities. So all the teams we are wanting to do end-to-end adoption of digital health there. And what we have also done since last September is that in each state, we are working with the state team to identify 3 or 4 hospitals, be it a district hospital, be it a community hospital, be it a PHC, be it a private hospital. Over there, if we can show it end to end, right now, what you see in UP and what you see across the country is that scan and share. It's like 80%, 90%. But then after scan and share, it just fizzles out. Like DG Yatra, which takes us when we enter the airport to when we take the flight, can we like have something which is called as the health yatra or AV yatra, wherein a patient enters through her Aadhaar, and by the time she gets discharged, that thing helps the patient. Can we think of uh, such concepts, and can we address the inefficiencies which are there both at the administrative level as well as at the clinical level? Um, um, those are some of the things that we have to focus on more in ABDM 2.0. Yeah.
And so maybe also before they reach to hospital, because we as a country are so health reactive.
Yeah.
But maybe with this all digital data about patients, they have more information about their health and maybe can take care of their health. Anaita, I want to now come to you. In your new role, you are seeing the AI and digital innovation across the globe. While this technological advancement happening, as you also mentioned, our medical education has been slow to incorporate that into the curriculums. Uh, how do you see that for the future, and how do you feel Indian healthcare is ready with the pace at which this digital innovation is changing?
Then, do you want to start it? I can go.
You go ahead and
Okay, sure. I think going back to how Anand's initial note on digital India and skilling, I think there's habit to want to walk this path. I think we're just trying to figure avenues and pathways, and for once, we can't say one size fits all for this one. And that's where we're trying to be innovative in multiple ways to bridge this gap. I think the medical college student example was one of them. But taking the efficiency gain example, right? Actually, I just do this. How many of you have heard of the PHR app? Okay. How many of you use a PHR app? We are well privileged people, right? And the idea is ultimately whatever we are talking about needs to benefit each of us. Sure, as somebody who works with the Gates Foundation, I'm much more targeted in whatever work we do at the bottom of the pyramid, and that's where we want to be able to add value. But this is where it starts, right? We are people, I'm assuming, who are playing some role, whichever way possible in the ecosystem, truly make this useful for the end beneficiary, which is all of us included, even the privileged. How do we make sure our understanding and the value add we think it can have truly translates into a value add which wants us to adopt it in the first place? Because it's easy to talk about Digiyatra because many of us have seen the efficiency gain. And we find it useful. We may have opinions on sharing data, not sharing data, so on and so forth. But then the same thing needs to translate into practice. And I think to what Sir said, I think some of these value propositions or use cases of how do we make sure the benefit is there, which is going to be very nuanced for each of us. When my mom uses it, it's very different. When my grandmother used to ask about it, it was very different. What is in it for each of us to be able to want to use it? I think becomes very, very important from a citizen lens. From a provider lens, I feel we need to take the hard road of making this mainstream. And I mean, a bit of a call to action for everybody here who I'm assuming has some work to do on the digital space or the other, because how do you not work on digital these days, right? Even when you think about AI, going back to your question, Umesh, is there really a value add? Or I think it's great where we can put and deploy AI assistant tools. It's great, we can use analytics, but now analytics is being confused with AI, NLP. I mean, when you look at multilingual languages, etc., there is a lot of value, right? Because even if somebody does not want to download a phone, you can talk to them, they can call somewhere, WhatsApp can be used. But does everything need a digital application? Just understanding what the needs of consumer are this is like 101 MBA kind of things that we are taught, right? I think that's increasingly becoming important. So I don't think there is any one pathway to your question, but I think every time we think about leveraging digital, especially for health, we need to be a little thoughtful going forward on how is it going to add value. Because if you want anything to stick, behavioral science says that it has to have some benefit before it can actually translate into something that becomes a habit. And I think that nuance we keep on forgetting. So I remember in 2016 when TECO was introduced, it's a frontline worker platform, and I visited Gujarat. I had asked, and the ANMs were adopting TECO, and that was the first time the frontline functionaries were adopting a platform. And I remember talking to this ANM who was very excited to show the demo to me. And she's like, what is in it for you? She's like, it's like me brushing my teeth in the morning because I need to know, I brush my teeth in the morning and I need to know mujhe kitne ghar jana hai aaj. So she found that to be a value add for her. So I think similarly for district officers, for block officers, when they have to go for a visit and they have to come back with a feedback on kya mila, kya nahi mila, kya galat tha, kya sahi tha, and then report back to their supervisors. How do you meet them where they are at? I feel we are all trying to find ways to do that, but my call to action in this room would be that please keep on sharing the different pathways you're able to, test in different models. Whether it can, be leveraged by the NHA, whether it can be leveraged by a state team, whether it can be leveraged by an NGO. I think there is a lot of work to be done. But making this center stage becomes equally important because in the scheme of things, उनको 50 चीजें हर रोज आती है, 10 circular आएंगे, उनको फिर एक campaign करना पड़ेगा, it just gets lost. So how do we keep building that? And the second thing would be, as you work in different states and with the ministry and are part of different work streams in this area, try to identify champions. You'll always find these pockets of champions who actually at the last mile become really useful. And for different beneficiary group. It happens in our own offices, right? So many times somebody's new tool, MS365 was introduced in my office the other day. And I was like, acha, isko istemal bhi karna hai. Acha, kaise karna hai? So I was like, okay, I should be knowing this. To kar liya, right? But if I found some champion in the office, I'll be like, batao bhai, kaise karna hai? Very, very privileged example. But technology space is so fast right now. And if we keep wanting to introduce things, we need to identify who can be that safe space to ask those questions, which are not easy to. Thanks.
Thank you. And then my last question to you is, UPDSU has led some really large-scale capacity building program across the states, maybe nurse mentoring platform. You spoke about the surveillance tool, the comprehensive primary healthcare platform for the frontline health workers. What are the two lessons that you think this capacity building programs, maybe all the states can learn, audience here can take away with them too? I have to be mindful of the time.
I think the biggest is the style of teaching these or rolling out these applications. I think in the past, people have been guilty of saying, let's go out. We have a framework or an application. Let's go out and find out what this person needs, and we will customize this application to them. Customize it to the next facility, customize it to the next audience. And before you know it, it's an exercise in futility because you can't support so many variants of the application. So I find that the way applications are implemented are not kind of templatized. What we need to be able to support them, this is not is a templatized kind of a way of implementing. That also brings us to the capacity building aspect, because as I told you, the user base keeps changing due to attrition, due to movement, etc. So we have to make sure that the system's kind of similar, that then training can be modularized, can be templatized, can be put on an online platform. People can be directed to that platform to learn on their own, or through, if you look at the similarity between what Sir said and what Anaita said, both of them spoke about organizational champions and individual champions. And I think that is needed in each facility. People would go and do a train the trainer project. That trainer would disappear along with the training, which means that now the staff is really struggling to work with the digital tools provided, and that creates a problem. It's easy for people to step back and say, let's go back to the previous paper-based world because things were more robust then, right? The last, I think, is strong leadership, because it's a serious commitment to move to a digital platform. It means that for a little while, of course, people in the initial period will continue to do their paper-based recording for pure, just to make sure that digital system picks up everything which was being done. But we know that in what happens is oftentimes you never see the next step, which is that those paper-based tools are removed. So what happens is that people do see the systems as being an added burden to them, as additional work, which is totally useless, right? Because we are doing it on paper still, and the paper is still moving around. So I think strong leadership which remains committed to the larger vision of the digital rollout or implementation is key. Things do go wrong. Those leaders have say bite the bite your teeth, then bear it, move forward, solve the problem, but don't go back to the paper based system.
Thank you.
So I
Yeah,
know
please.
this last.
Yeah.
I wanted first on my earlier question we moved to my the government's view on what's in it for India. I feel
Yeah.
very critical.
Yeah, before that, just on what he was saying, because when it was told that people in the villages, they are using WhatsApp, they are using YouTube, they are watching the reels, and they are very comfortable doing that. One of the learning for us has also been that while we are creating the technology, while we are creating those tools, can we try to make it very easy? Can we make it very intuitive? Can we reduce the number of clicks? So this user, the UX part, the UI UX part, we are also trying to give more attention to that so that it becomes very easy for them. Yeah.
Yeah. I've seen some of the rural farmers using audio feature in YouTube to search. So maybe, especially the doctor-patient interaction, have a huge scope of maybe transcribing through audio using AI.
My doctor doesn't know how to write. But जब उसको मैं बोलता हूँ कि इधर जाना है तो फटाफट गूगल मैप में
Yeah,
आता
audio.
है and he will.
Yeah.
So yeah.
I have a few questions for the panelists, but in the interest of time, we'll open the floor for the audience questions. Do we have any questions for the panelists? Please raise your hand and we can maybe state your name and ask.
Hi, I am Dr. Anuradha Jain. I represent ISPP, Indian School of Pharmacy. So please don't, I'm starting with a disclaimer. Don't think that I am I am mispropagating the technology in any. This is just a worry that I have, having been worked in the field for 20 years. In the demand for making technology upfront in terms of everything, so it's the new buzzword of the public health. Are we not leaving behind connecting it to the outcomes the field? So what I would request, and Anaita and Anand coming from UP, is there a way to design the connect between your capacity building, digital capacity building, to how it can actually result into a better outcome for beneficiary? So any kind of mathematical model, if you can build and prove it that by doing a digital training, your outcomes are improving. So that's one question. And the other is that Vikram just mentioned that in the version ABDM 2.0, we are trying to, pick up model facilities where we are making that Digi Yatra example into health. So health Yatra. However, I believe that, as very rightly said by the moderator, that India is a country of reactive care, not a care which is seek for in terms of preventive care. So why do you think people would want to undergo that health yatra with you, unless and until they understand that the health yatra is important to them? So can you prioritize some of the diseases like sickle cell anemia, diabetes, hypertension, where you are going to have chronic impact, prove the case in scenario for such a effort to be taken by a patient, and then expand it further? This is a suggestion and query both at the same time.
So again, I think in my role, digital is linked important, right? And this is Anand and my everyday interaction as well, which is that great, good tool, amazing, done a fantastic job. We've designed it. It has the modules. Maybe it can be integrated or whatever. But what's the value of it? We're in service of health goals. And one of the things we were doing in UP where we got some initial insights, and the idea is to do exactly what you're doing, right? Otherwise, none of this really. If I am being trained for something in my job, it has to translate into whatever outcomes are expected in my responsibility in that job. So completely, and this is much more critical than saying something like that as an analogy. So what we recently did was with the tools that are available in similar work being done by our partners in Bihar, and many other states are doing this now as well, is that try to understand what the journey of anemic, severe, moderately severe anemic pregnancy. And if these trainings happened, if these digital tools were in place, if the tracking happened on time, if the identification happened on time, if it was not reactive, it was prevented. And if the treatment protocol was followed, there was no fallout from the backward forward referral. And the loop was completed and she was given the attention she needed in whatever format at different stages. How does that really benefit? And we saw X percentage improvement in many of those things. And this was not a perfect system. Like I'm saying, we have digitized systems of frontline workers, we have digitized systems of the facility. We tried with lack of integration or necessarily interoperability yet, including labor. We tried to at least create that flow through what that data workflow would look like, whether it was integrating with those digital systems and using a WhatsApp or using an Excel or whatever the case might be. And we tracked that and we saw that. So none of this is useful if what you're saying is not done. And I think that is always what is in the center of what we want to think when it comes to the provider side. The citizen side, I'll let, if you want to add anything, I'll let this.
Maybe just a couple of lines about each of the points you mentioned. A, we tend not to lead with digital. We always lead with a specific intervention to address a problem in the healthcare domain, in the healthcare ecosystem. There are specialists who work on the various aspects of that problem and its solution. And then if digital can help those solutions, that's where we put in digital. So we're not digital forward just because the technology is available. The second aspect, digital often is like water, the availability of clean water in a hospital. Does the plumbing there help the doctor save lives? Dutifully, I think all of us would agree that yes, it does. Clean water is important for the patients and also for all the professionals with it. So the water is important, but it's hard to kind of correlate the availability of the water with the outcome because there are so many other elements along the way. Do we see capacity building and do we look at outcomes? I'm very happy to say today's opportunity. We've just launched today the ability for SNCU, which is in a higher level facility, specialty newborn care unit, sick newborn care also, to take care of the NBSU, which is at a far lower level where specialists are often not available. Now, we are using technology to provide specialist care to children there. Will it help outcomes? Will that technology help outcomes? The answer is yes. Once we roll it out for 6 months, 1 year, we'll actually be able to have data. And trust me, there are enough people in the organizational pyramid who are working to make sure that every intervention, because it's money, it's resources, it's time, is spent in something which yields a measurable outcome.
And later in the presentation, we'll have a segment. I'm using my moderator right to keep one question because I think to cover all, and ma'am will be, after the event, we'll have individual interaction with sir. Maybe, and please, one question and a brief. Anyone from audience?
Good evening. Thank you very much for talking about the digital health capacity building program. My question is specifically to Mr. Vikram Pagaria. What is the plan for, we have kind of piloted this in UP, but what's the plan for taking some of these things that we have learned across India? For example, in Rajasthan, where we are coming from IIM Udaipur, we would be interested in taking up something like digital health capacity program for the ANMs. So, what's the plan from the government side on rolling this?
Yeah, we also want to be uh, go to go past capacity building. The work that has been done in UP, we will have a look. And what we have also started to do recently is something which is called as state exchange, where states who think that they can nominate themselves, and who think that they are doing good, they can share what they are doing with other states. And not only NHA, um, instead of becoming an intermediary, it could be state to state translation also. But taking what UP has done, we will definitely circulate it with all the other states, and whoever wants to pick it up. And even if there are, I'm sure there would be some lessons for the central, at the central level also. So we'll take them forward.
Later today, we will also have some sharing from organizations who have used the similar framework and implemented in their states. So maybe some learning can be happening from. We'll take the last few questions from this side.
Hello everyone, my name is Shivani. I am representing this organization called Center for Effective Governance of Indian States. I was with UPTSU earlier, so I'm really happy to be here. One question that I have is that when you working on this platform, developing this platform called Ishamata, as part of UPTSU, I remember speaking, like giving a demo to a couple of PNMs in Bahraich, Uttar Pradesh, and I remember this was just a demo where the nurses, the ANMs were actually taking a couple of assessments, like competency-based assessments on the platform, right? And I just explained to them ki, Didi, this is not going to be, we are not scrutinizing or something. This is because they were really, really worried about, even in the demonstration phase, am I getting, are there eyes on my, while I'm actually, just going through the demo phase. So I just want to understand, how are we as people who are working on, frameworks, designing and all of these things, are we even considering some of these aspects of, prioritizing the intent and purpose of these interventions over the procedures and the process part of it?
It's fair to say, as we spoke about in other areas, fear, uncertainty, doubt are rampant whenever we bring in such systems. Doctors are worried that ABDM is all about finding out how much money they make. Nurses are worried that when you put in assessment systems, learning management systems, it will be used against them. I'll draw parallel to a different domain altogether and give you a sense. When QA was first introduced into manufacturing systems or into IT organizations, the first response of everybody was, this is going to be used to penalize us. It is upon the leadership to make sure that even though the tool gives you the ability to penalize individuals, you stay away from that aspect of that tool and use it instead to overall improve the process flow or the ecosystem as a whole, and not penalize the individual. So it needs, I think, all the people sitting in the pyramid of the ecosystem are familiar with these learnings from other domains, and they will all make sure that these are not used for that purpose. The purpose, for example, ABDM clearly is to create digital health record for the patient, make life easier, to improve the quality of care the citizen receives, because the clinician has access to the right information at the right time. That's the goal. All the other things we have to work to overcome. Those are the barriers in people's mind. We have to educate them. It's through training, it is through IC or behavior change communication, it is through radio, TV messaging. You really have to work on multiple ways, but that is important.
We'll have our panelists with us after the event, so I will request to hold your questions and ask them after the thing. It's been a privilege. Thank you so much. My 3 takeaways from this sessions are not using technology just for the sake of having it available, maybe to solve a specific problem. And as Anaita said, maybe meeting our health force at where they are and not we think we should there. And also looking at the whole capacity building as a convergence effort between all the stakeholders. We are seeing that something like a one cadre, one state took us 3 to 4 years to reach to a point where we have, but this is just a start. Going forward, we are seeing a lot of convergence at Sir shared, maybe ideas exchange between state to states, organization to organization, and professionals to professionals. With that, we'd like to end this with a small token of appreciation from IIC to all our panelists. I request Himanshu to maybe start with Vikram sir. I request Rukmini to maybe also give it to Anaita. And request Chirag to maybe give it to Anand. Thank you so much for joining us.